வியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Dr. Bhuvashri, please come. இதை படிக்கணும். ஐஎம்ஏ ப்ரேயர்னு சொல்லிட்டு இதை படிக்கணும். அடுத்தது ஃபிசிஷியன்ஸ் ப்ரேயர்னு சொல்லிட்டு இதை படிக்கணும். அவ்வளோதான்.
IMA prayer. May every day be happy. May every day be healthy. May every day be free from pain. May every day be free from sorrow. May we be the healthy cure beyond every greed and lure. Physician's prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee, I pray. Give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give singleness of purpose, strength through life, at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I rely on thee. Thank you.
Thank you, Dr. Bhuvashri. Please be seated. So we have 3 talks today. The first talk is by Dr. Mohana Priya, radiation oncology resident. Improving risk. She is speaking on improving risk stratification, optimizing clinical outcomes in rectal cancer. This session is moderated by Dr. Rajkumar Ratnasamy sir, Dr. Joseph, Dr. Dominic sir, and Dr. J. Surendran sir.
Very good afternoon to everyone present here. I am Dr. Mohana Priya, second year resident from Department of Radiation Oncology. So today I will be presenting in the topic related to the rectal cancer, which is improvising the risk stratification and optimizing the clinical outcome in the rectal cancer. Introduction. Like lung and the breast cancer, colorectal cancer is also a major worldwide health problem with an incidence rate of 1.9 million new cases per year and 9 lakh deaths per year. And the statistics released by the Globocon 2022, it showed that colorectal cancer is in 3rd place globally and 6th place in India. And this is the Tamil Nadu cancer statistics published in 2021. It also showed an increase in incidence of the rectal cancer in Tamil Nadu, and this is the district statistics of the rectal cancer. And considering the increase in the incidence and the morbidity of the rectal cancer, it is the right time to discuss about the risk stratification and the management of the rectal cancer. And the definitive treatment for rectal cancer remains the surgical resection, and it is also important that we should achieve a negative circumferential resection margin, which plays a major role in the prognosis of the treatment. And the surgical approach involves total mesorectal excision preceded by the neoadjuvant chemoradiation therapy for the locally advanced cancer. And what is the locally advanced cancer? It is the T3 or T4 stage or nodal involvement without the distant metastatic disease. And the core problem is that there is a different outcomes seen in the same stage, and which leads to over-treatment of the patient and also under-treatment of the patient. And why risk stratification matters? So it helps to predict the local recurrence, distant metastasis and survival of the patient, and it also guides for the neoadjuvant therapy, surgical planning and organ preservation. And it also helps to avoid the toxicity and unnecessary treatment for the patient. Evolution of the risk stratification. The earlier approach was it is only TNM staging, and the limitation is that same stage will show the different outcomes, and also it cannot predict the response to the therapy and tumor aggressiveness, and there is also no insight into the tumor biology and microenvironment. And here comes the modern risk stratification, so which includes the clinical factors, pathological factors, imaging, which is MRI based PET-CT imaging, molecular and emerging biomarkers. So the risk stratification includes clinical, MRI based and pathological. In clinical, we should consider the tumor, location of the tumor, distance of the tumor from the anal verge and relationship with the sphincter, size of the tumor and symptoms like obstruction, bleeding and perforation in the advanced diseases, and elevated CA level is also associated with poor prognosis and performance status of the patient, which impacts the treatment tolerance. MRI based risk stratification. The role of MRI in rectal cancer management has significantly increased over the last decade, and total neoadjuvant therapy played a pivotal role in the shift from the traditional surgical approach to a non-surgical approaches such as wait and watch. And MRI based circumferential resection margin, extramural venous invasion, tumor deposits and MRI tumor regression grade. So it is proven that these are all valuable for staging, response assessment and prognosis of the patient. And other factors seen in MRI are distance of the tumor from the anal verge or anorectal junction to the lower aspect, length of the tumor, T staging, tumor deposits within the mesorectum, involvement of the mesorectal fascia, end staging, and presence or absence of suspicious extra-mesorectal lymph node involvement. A positive CRM is defined as a distance of less than or equal to 1 millimeter between the tumor or the irregular lymph nodes and the mesorectal fascia. So it is also the strongest imaging biomarker to predict the local recurrence, and it is a prognostic factor for disease-free survival and overall survival. And the outcome of TME surgery depends on the tumor's relationship with the mesorectal fascia. Extramural vascular invasion. So it is like when the tumor signal extending into the adjacent vessel, or when the vessel is extended by the tumor, or if the tumor disrupts the vessel border. And it is a strong predictor of the disease recurrence, particularly in the systemic failure as well as synchronous and metachronous metastasis. And a positive EMVA correlates with reduced disease-free survival, and EMVA positive stage 2 disease shows similar outcome with the EMVA negative stage 3 disease. And grade 3 and grade 4 is reported as EMVA positive, and grade 0 to 2 is reported as EMVA negative. Tumor deposit. So it is a discrete nodule present in the pericolic or perirectal fat within the lymphatic drainage area of the primary tumor without the identifiable lymph node. And it is the nodal classification is N1C, and tumor deposits will be irregular in shape. This is the tumor deposit, and it will be irregular in shape, contiguity with the veins, discontinuous from the primary tumor. Often it is associated with EMVA and node equivalent to positive node, and it is also a negative prognostic factor. Pathological risk stratification. So we'll be considering the histological type, grade of the cancer, depth of penetration, number of lymph nodes involved, and status of the proximal, distal, circumferential and mesenteric margins. So circumferential margin, which is a powerful predictor of local recurrence in patients treated with the neoadjuvant therapy. And neoadjuvant treatment effect as per CAP guidelines. Earlier it was 5 grading system. Now it is we are using modified Rayon scheme for tumor regression score, which is 0, 1, 2 and 3. And then lymphovascular invasion, perineural invasion and tumor deposits, tumor budding, which is defined as a single cell or a cluster of less than or equal to 4 cells, which is detected at the advancing edge of the invasive carcinoma, and it is also identified as a new prognostic factor in the colon cancer. It reflects an aggressive growth pattern, and it is of 3 grade, low, intermediate and high grade. Low grade is 0 to 4 tumor buds, intermediate is 5 to 9, high grade is more than 10. Next comes the molecular markers. So microsatellite instability or mismatch repair. So the incidence rate is 15 to 20% with stage 2 and stage 3 colorectal cancer, and the types are MSI high or deficient MMR, and MSI stable and proficient MMR. The clinical significance is if patient is having MSI high, it shows a better prognosis and poor response to the 5-fluoropyrimidines chemotherapy, and it showed excellent response to the immunotherapy. Since deficient MMR and MSI high tumors are highly immunogenic, so patient will respond well to the immune checkpoint inhibitors like dostarlimab and pembrolizumab. Next is RAS mutation, KRAS and NRAS. It is found in 40% of the colorectal cancer, and if tumor is RAS mutant, where the anti-EGFR cannot be used in these patients, and so it is always mandatory to check for the RAS mutation before starting an anti-EGFR therapy in metastatic disease. And BRAF mutation, so the common is BRAF V600E, and the clinical significance is it showed poor prognosis and associated with aggressive tumor biology and higher metastatic potential. HER2 amplification, so it is also relevant in the rectal cancer, and if patient is positive for HER2 and these patients are resistant to anti-EGFR but they respond well to the HER2 dual blockade agents like trastuzumab and lapatinib. And so the integrated risk stratification including the clinical, pathological and MRI, so it is divided into low risk, intermediate and high risk. So low risk includes T1, T2, N0 with CRM more than 1 mm clearance and EMVI negative with well and moderately differentiation. Intermediate is T3A and B, N0, N1 and threatened CRM with negative EMVI, and intermediate risk group patients will be decided on treatment based on the risk factors present. If the patient is having only T3A or B and N0, patient can be taken up for afferent surgery, or if there is any presence of threatened CRM or EMVI positive, so we can decide on neoadjuvant therapy followed by surgery. And high risk group, it includes T3C, D and T4 N2 disease with CRM less than 1 mm and positive EMVI, presence of tumor budding and poor prognosis. And the options of treatment in rectal cancer are first is upfront surgery, neoadjuvant chemoradiation therapy followed by surgery, and total neoadjuvant therapy and surgery. And we usually discuss the both intermediate and high risk rectal cancers in the tumor board, and after making the decision we'll be planning the treatment for the patient, whether to go for upfront surgery or total neoadjuvant therapy or neoadjuvant therapy followed by surgery. And thank you.
Very good afternoon to everyone. To emphasize the treatment of colorectal malignancies, first of all, I would thank the tumor board members, because after starting every case of CA rectum into the tumor board, the clarity and the depth we discuss gives us immense knowledge and the surgical plan to treat the diseases in a very methodical and scientifically topmost treatment is able to be delivered because of the preoperative discussions. So every case of rectal malignancy, the treatment part, either in the form of surgery or in the form of chemotherapy or in the form of radiotherapy, all the tri-modality of treatment is very essential. But when to give what treatment, that is the priority in such decision making in tumor boards. So I thank all the tumor board members, especially Madam Kala Madam, Dr. Vijay, Dr. Surendran sir, Dr. Karthikeyan Perumal sir, Dr. Ronita, and it is always led by our captain Dr. Dominic, which is the stalwart of the tumor board. So I want to emphasize the modality of treatment in the form of open surgery, laparoscopic surgery and robotic surgery. Here we not only treat the disease but also the mental status also of the patient, because every patient is fear of having a stoma. If we give the right treatment at the right time, majority of the times, almost more than 90% of the times, we may able to spare the sphincter, so we can preserve the sphincter and give a good quality of life in terms of bowel movements. So one such case is this. So this is a case of 56-year-old male known case of Parkinson's. Madam is going to talk about Parkinson's. Thanks for referring this patient to me, madam. He presented to me with the bleeding PR and constipation with a significant weight loss. And we did an endoscopy. Endoscopy shows that there is a clinical examination shows that there is a growth at the anus. So I said that this is a anal growth. We proceeded for endoscopy to look for any synchronous lesions, because almost 5% of the cases have synchronous lesions somewhere else in the colon or rectum. So this patient has got anorectal growth as well as an erectosigmoid growth. So two primaries with a distance of about 10 centimeter in between. Proficient. And then imaging was done. The imaging shows that there is an instance where we cannot spare the sphincter, because once the sphincter is involved, we have to remove the sphincter and then patient has to be in stoma permanently. But in this case, there is difference scenario, and there is mesorectal infiltration, EMVI positive, nodal disease. All this shows that the patient has got a locally advanced disease. So if not treated, the patient would end up in a metastatic disease in a short period of time. And PET CT shows that there is an uptake in both the primary. So the challenges in this treating this kind of patient is the patient is a Parkinson's and recently lost one, and he is a government servant. He is yet to retire. So lot of social responsibilities for him, because a Parkinson patient cannot put a stoma, cannot take care of his stoma on his own, and he has to frequently empty the stoma quite often. Every 2 hours, 3 hours he has to empty the stoma. So he always need an assistant to do that. So we were thinking in every possibility to spare the sphincter and then avoid stoma with obstruction. So there is a necessity for the diversion colostomy. So there was a diversion colostomy was done. So the challenges in this patient is to give a radiotherapy, because the lower segment anorectal growth will respond to radiotherapy. But by the time of giving the radiation, the duration extends. We cannot give the radiation to the upper rectum, because the upper rectum radiation would have some detrimental effect on the small bowel. But at the same time, the upper rectal tumor might likely to metastasis also when we are extending the duration with the chemoradiation. And the preservation of sphincter is questionable, because already the sphincter is involved by the tumor. And then to avoid the stoma, to maintain a good quality of this patient, because he is alone. So that is also, these are all the challenges we all discussed in detail in our tumor board. And as he presented with the impending obstruction, I did a diversion colostomy. Then I submitted in tumor board, and then we decided to go for the neoadjuvant chemo RT for both upper tumor as well as the lower tumor. Sometimes the lower tumor, the aim was, if the tumor was responding well, then we can do upper tumor and then we can reunite it. If the tumor does not respond, if the tumor is progressing, then no other choice, we have to keep a permanent stoma, what we did earlier. So this was our aim. But surprisingly, unfortunately, after giving a radiation, we assessed him with the response assessment scan. The MRI shows that it's a near complete response to anorectal tumor and a partial response. She mentioned that the tumor regression grade, pathologically and radiologically also, there are tumor regression grade. The tumor regression grade has come to 1, that means it's a significant response. So with this background, it has to be confirmed by means of colonoscopy and biopsy. Thickened mucosa in the anorectal junction and the partially proliferative growth still there in the upper rectum. So biopsy from the lower rectum reported as no evidence of malignancy. That means the anorectal growth has completely responded to the neoadjuvant chemotherapy. That was a good thing in this patient, but the upper rectal growth showed that the residual disease. So the final histopathology is, this is for this final, that is different. So he has good response to the anorectal tumor with the poor response to the upper rectal tumor. So what we did, we proceeded for surgery for the upper rectal tumor. The challenge is here, there should not be any marginal involvement, because the upper rectal, the in between is only a 7 to 8 centimeter difference. So I have to give a clearance of the upper rectal tumor also. At the same time, I should not include in the lower rectal tumor also. So it has to be very much calculated, and then the tumor has to be resected. So in such a manner it was resected. That was very helpful in radiological assessment. So that tumor shows that there is a margins was completely negative and no lymphovascular invasion, perineural invasion, and that tumor was T3, that is the upper rectal tumor. So now the upper rectal tumor has been removed, the lower rectal tumor has been completely resolved, there is no residual disease. Now the patient has been restored with the stroma after 2 months. Now the patient is living without disease, without stroma, only taking treatment for Parkinson's. So this is the colonoscopy. You can able to see that pre-treatment and post-treatment. You would able to see that the lower rectal tumor on the right side and the upper rectal tumor. The lower rectal tumor has got only thickened mucosa post-irradiation. Upper rectal tumor has got still relevant residual disease. So this is the imaging also pre and post treatment. You would able to see that regression of the disease in the lower rectum. Marker rakama. Marker raka. Ilepa. The main force behind this treatment modality to preserve the sphincter is Dr. KP. So this is the post-treatment. It's a good response to the anorectal tumor. And this is the PET CT. So here you would able to see that the response, the initial lesions has got 2 lesions and later lesions does not have any active uptake. So this was the thing. Coming to the robotic no, not this marker, ma. Pointer kettamma. Coming to the robotic experience, after launch of robotic system into our institution in May 2025, from the Department of Surgical Gastroenterology, we did almost nearly 135 cases. Of that, colorectal is 20% and hepatobiliary is 40%, upper GI is 5%, and abdominal wall reconstructions, that is hernias, almost 69%. Regarding colorectal malignancy, this census from the 2024 to 26, almost 645 cases, 35 cases we operated. Of that, 13 cases have been operated by robotic system, and then 20 cases have been operated by laparoscopic colorectal malignancies. So this was the patient. So he is a Parkinson's patient. This is the stage in which where the stroma was there. Then later the stroma was restored. So how difficult for him with a tremoured hand. So he is still in government service. So I think, so this is the impact of the multidisciplinary team of giving a life to the patient. Thank you. Any doubts? Any comments?
I think if there is a hero in this story, it's the radiology team. Particularly because we've been doing things like this for a long time, but what has changed, at least in the past 5 days, is the role of the MRI. And the ability of the MRI to identify whether we will have a complete surgery or not at the time of diagnosis is what has made a major impact. So, though we will as oncologists like to take credit for this, I think the true credit should go to the MRI and that should become the hero of the day.
This is the robotic video clips, just 4 or 5 minutes. So the colon is being mobilized. The sigmoidorectal junction is being lifted up from the presacral region. So the underlying vessel that is pulsating is the common iliac artery. So that is a ureter. So it's a complete mesorectal excision. That's what she mentioned about that, TME. So we're entering into the TME plane, presacral region. Underneath is the presacral venous plexus. So this is the arterial supply of the rectum. That is from the inferior mesenteric artery. Here, multiple arteries are feeding into the tumor. See the superior rectal artery, left colic artery, and sigmoidal branches. All the branches are clipped. At the root level, to have the high lymph node yield rate, then the colon is mobilized all around from lateral aspect, from the pelvic side wall. So the entire left colon is mobilized to have the free and fair anastomosis down to the rectum. So that is a rectum tumor. In case of clearance for the margins, we do an intraoperative colonoscopy also if required. That is a left ureter. So we do an intraoperative colonoscopy also to find out the tumor location, to assess about the distal margin clearance. Then the ICG mode, which is to assess the vascularity of the bowel. This is a boon in robotic system. So where to dissect the vascularized segment, the differentiate between the vascularized segment and the devascularized segment. So that is the sign of the devascularization. Up to that level, the bowel is highly vascular. So we assess with that, and then we dissect the tumor at that point. Then the tumorous part has been excised. After that, it is reinserted, and then with the lower end of the rectum, the upper colon is anastomosed with a staple. This is a circular stapler, thereby maintaining the colonic continuity. So this is another patient who walks immediately on the next post-op day. So this is the quick recovery from the robotic surgery. Thank you.
Doubts or discussions from the audience? Yes, sir.
Thank you, sir. Already, sir has all covered most. So the important thing that we as radiation oncologists wanted to say is there was a controversy on whether to radiate the rectosigmoid junction. That It is not clear whether we can radiate the rectosigmoid, is it in guidance, all those things. And if we didn't radiate the rectosigmoid, the tumor would have progressed. So there was a huge dilemma whether to radiate the rectosigmoid to at least arrest the growth and at the same time attempt the sphincter preservation, or do a more aggressive surgery. So doing a more aggressive surgery was not an option in this particular patient. So we took the chance and we did radiate the rectosigmoid. We do have lot of literatures, lot of trials which accepts the radiation of the rectosigmoid. Fortunately for him, the rectosigmoid at least it gave a partial response. It didn't progress, the disease didn't progress, and it gave a complete response. So we were able to do the organ preservation for this patient. We took a chance and we were able to do. And thanks for the medical oncologist cooperation as well, and also our wonderful surgeons discussion and cooperation. Because of the team effort, we were able to give at least the initial success. So that is about it. Thank you, sir. Thanks.
That was a great presentation. Next we have Dr. Sairam presenting on changing concepts in Parkinson's disease as a neuropsychiatric disorder. Chaired by Rajesh Aripan, the team of neurology.
Hello, good evening everyone, good afternoon. Sir has presented some exciting surgical findings, and I hope to give you some exciting updates from the medical side. So we have always had a particular view of Parkinson's disease as being a motor problem, and the concepts are now changing, and I'm here to update you on what's new. So the current model, what we have all been taught so far, is that Parkinson's patients who present to us with rigidity, bradykinesia, and tremor, and we thought that that encapsulated most of what Parkinson's was. Everything that happened apart from it, all of the non-motor features that we know of, sleep issues, psychiatric issues, we thought happened as a result of the disease, as a separate entity. But now we're finding out that that's not the case, and that neuropsychiatric manifestations are a big part of the pathophysiology of Parkinson's. So we have now come to understand that Parkinson's is something that involves the entire brain. There is limbic and cortical involvement, which goes much further than the nigrostriatal pathways that we initially thought. The amygdala, the hippocampus, the cingulate gyrus, and the prefrontal cortices are all involved. The neuropsychiatric manifestations in many cases come before the motor components. So depression, anxiety, REM sleep behavior disorders, and hyposomnia may precede motor features by up to 5 to 10 years. And assessing these and being able to pick these up earlier will give us an opportunity to also offer treatment much earlier. So this is the Brack's staging, which is the sort of new concept, and this shows us that in the initial stages of the disease, the pathology is localized to the parts that we know, the olfactory node and also the lower brainstem, where we have some motor features and loss of smell. After this, it moves up to the mesotemporal cortex, and here we have sleep issues, and you can see that it spreads to pretty much the entire brain. And with this, you get a lot of other symptoms like emotional and cognitive symptoms, which we should start screening for much earlier on. So the pathophysiological advances is, the first thing is alpha-synuclein. Alpha-synuclein has been thought to behave like a prion. It's a monomer which starts off, which progresses, polymerizes, and eventually forms a Lewy body, which then wreaks havoc in the neurons. And these Lewy bodies have been found to progress through the brain, starting from the midbrain and then towards the cortices. And as they progress, they cause issues everywhere they go. So you can see here that this is where it starts in stage 1, moves in towards the cortex, and then spreads all the way towards the entire cortex. And as this progresses, the patients also worsen in clinical features. Ideally, we used to pick them up when they got to this stage. We want to pick it up when they're here. So the second thing that we have now found out is that dopamine is not the only neurotransmitter that's affected in Parkinson's. We now know that serotonergic and adrenergic neurotransmitters and neurons are also affected, and so those have now become new targets of therapy for us going forward. So this is the pathways. Initially we were only worried about the nigrostriatal pathway, but now we are focused a lot more on the mesolimbic and the mesocortical pathways as well. This is what we used to care about. These are the new ones that we need to focus more on going forward. So the last and the newest possible advance is that we are now looking at the gut-brain axis as another possible pathophysiological mechanism in Parkinson's. And the thing is that both of these are alpha-synuclein based pathologies. And so if we are able to understand and stop these alpha-synuclein propagation, then we could essentially either stop or reduce the worsening of Parkinson's. And so this is where we're headed towards. So the neuropsychiatric manifestations of Parkinson's can present in three broad categories. They can affect your mood, it can cause psychosis, or it can cause cognitive and behavioral issues. So mood, it can cause depression or apathy, and it can also present with anxiety. In psychosis, they present with hallucinations, delusions, which can also be drug induced, which is also a big problem in treating patients with Parkinson's, especially chronic follow-up patients. And finally, you have cognitive and behavioral issues. So they present with Parkinson's disease, dementia, sleep disorders, and also impulse control problems. All of these can present 5 to 10 years before any motor symptoms. So anxiety, there's a 40% prevalence of depression and anxiety, of depression, 30% of anxiety, and in 50% of cases, depression precedes the motor symptoms. And like I told you, that now we know that serotonergic neurons are also affected in Parkinson's disease, which forms the biochemical basis of anxiety and depression. We typically treat with SSRIs and SNRIs. The dopamine agonists that we give also have an antidepressant effect, and MAO-B inhibitors like rasagiline also have a mood stabilizing effect. And now we need to work together with mental health professionals to provide cognitive behavioral therapy and exercise therapy as well, which can also reduce the mental health impact of this condition. Psychosis, most commonly patients can present with formed visual hallucinations, and this is also again chalked up to the serotonergic imbalance. And we have two drugs, bromamine and clozapine, which help us with psychosis in Parkinson's disease. And this is the most common thing we see is apathy, not full-blown depression. Patients will have loss of emotion, usually no anxiety. They'll just be indifferent to life and loss of interest in things that they used to be interested in before. And once, if this is left untreated, it can definitely progress into a full-blown depression, which again adds to the morbidity of the condition. Cognitive impairment now is become a spectrum. It's become a spectrum in Parkinson's disease. We have what is known as Parkinson's disease dementia, which is a part of Parkinsonism which precedes dementia by 1 year. And then we have Lewy body dementia, which coincides with Parkinsonism itself, and this is called the 1 year rule. Now we have CSF alpha-synuclein and skin biopsy showing alpha-synuclein, which can predict the severity of the dementia that happens. And for this, the treatments that we now have available are rivastigmine and donepezil. These are all medications that we always had. We just now find that they can affect these other aspects of Parkinsonism that we weren't aware of before. So these are the new treatment advances. Apart from the medication, we have deep brain stimulation surgeries focused on the globus pallidus and the substantia nigra, which can help motor control and mood and behavior symptoms. Then we have a next generation AI using adaptive closed loop deep brain surgery, which can also help with the same symptoms, which has shown great results in depression symptoms. So the current disease modifying therapies that are available or that are at least being investigated are GLP-1 agonists, which are everywhere. Which are everywhere all at once. So liraglutide and semaglutide are both being looked at. Then there are specific gene therapies that are available, and then now we are looking at specifically targeting alpha-synuclein. So we have the denosumab, which prevents alpha-synuclein from aggregating, and we also have active immunization strategies which also have the same role. They are small molecule aggregation inhibitors, so they inhibit alpha-synuclein from aggregating and forming Lewy bodies, which causes all the problems. So the biomarker evolution is what we can do at our level, is we can look for alpha-synuclein in CSF. We can also look for amplification of alpha-synuclein from CSF, skin and nasal brushing. And skin biopsy is also a possible diagnostic tool that we can have. And now we do DAT spec to quantify the dopaminergic transport in the nigrostriatal pathway and also quantify neuromelanin on MRIs. And now, as always, AI is used to augment this pattern recognition, which makes our job as neurophysicians a lot easier. So there is a new classification based on all of these changes. It's called the synergy framework, where the S stands for synuclein, N stands for neurodegeneration, and G stands for genetics. And this basically takes all of the features that we've just talked about and puts them into a single classification, which helps us give a more overall view of what kind of disease the patient has. So AI in digital neurology and Parkinson's disease is something that's come up very recently. Wearables and continuous monitors are picking up pace, and people are using smartphone and smart rings and key gadgets to look for things like tremors, facial expressions, and also sleep patterns, all of which can visibly change in patients with Parkinsonism. And if they have a genetic predisposition to it, we can start screening at a much earlier age. So, yeah, this is the takeaway for today, that neuropsychiatric manifestations can come up in Parkinson's up to 5 to 10 years earlier. And so if we have patients presenting to us with just neuropsychiatric manifestations, we should screen for Parkinson's disease. Yeah, thank you. Thank you so much for the opportunity. Ma'am.
Thank you. I should thank Dr. Narendran for taking up this subject in one time and making the beautiful slides. I have only 3 points to make. When James Parkinson described Parkinsonism, all those patients had those 4 features returning to motor symptoms, but they lived only for 5 years. The longevity of the Parkinson patients came only after the discovery of DOPA. Now we are giving DOPA right less, and these patients are living for more than 15 years, 20 years. Now we are able to see the extended pathology. Earlier what we could see was only nigrostriatal fiber involvement. Now it is involving all the cortical circuits, limbic circuits, and we are seeing a degenerative disorder in its full extent. That's what I think. Originally, James Parkinson did not miss any of these features. We are able to see because these patients are living long. How do we manage? We have a very good psychiatric management. We have insulin with that. Once you refer to our psychiatrist, we are able to manage very well. Certain things are still a problem for us. If you give a cell phone to these patients, they are more prone for addiction and more prone for impulsive disorder. They are losing money. Every day we are learning about this disease and the living standards and the newer drugs. get the drug to manage nuclear body, antibody, things like that, I'm sure the management will vary. Not only DOPA, DOPA is managing symptomatically, like giving kerosene to fever. Once we know to adapt the technology, I'm sure we'll have better management in future. Thank you.
Thank you, madam. It was a great, extensive coverage on broad extents. So we come to the last talk of the day by Dr. Devachandran. Sir has a very interesting topic to be very useful for the residents.
Teachers.
Doctors as teachers.
So good afternoon. Thanks to Dr. Sai and Dr. Anita for the opportunity. So I'm going to touch upon us acting as teachers, not as clinicians, for the next 20 minutes. That's my disclaimer. I'm just an ordinary learner. Definitely, I'm not an expert teacher. I'm learning every day, trying to improve myself in the way I teach the modern learner. So first of all, I need to tell you why I chose this topic. I have seen a very big change in the last 5 years with regards to how teaching happens, number one, the expectations of the learners, number two, the modalities that we use to deliver, number three. It's not GPT or Claude or other things, but in general, the way teaching is delivered has definitely changed. I'll tell you what has changed and why I was quite interested in this topic. The changes we've observed, not only the learner's content and also delivery, but I don't know whether we teachers have changed. I don't know, some of you might know, there is a very nice journal, peer-reviewed journal called Medical Teacher. It comes out every month. In March 2026, there was a beautiful piece on teaching by humiliation. The first topic in that particular journal was teaching by humiliation. And we can all certainly relate to that. When we were learners, when we were students. I'll tell you how the situation is now towards the end. So first touch upon learners. Who are we actually teaching? I'll tell you, you all know that critical care got the DNB. This year we got 2 seats. As soon as the exam got over, when they started the counseling process, I haven't fully understood how it works still. When the counseling process started, I started getting phone calls and people started visiting our department. So total of 5 people visited and I received 1 phone call. Most of the people that called are already working in medical colleges, Savita, Chettinad, etc. Some physiologists, general medicine trainees, etc. And I've highlighted the questions they asked me, whether in person or over the phone, in green. They asked us the first question, all the prospective candidates asked, even before they filled in their choice filling, was, what are the working hours? How many hours am I supposed to work? Second, what is the monthly pay that I'm going to get? Third, do you have ECMO in your unit? Do you do ECMO regularly? Fourth, about the accommodation. And finally, work environment. How is the general culture here, etc. I was just thinking back, what did I do when I joined post-graduation? I did none of this. Okay, so we just got a seat, we went there, joined, and whatever was there, we studied. Okay, so that is a big shift. That is a very big change. What I was expecting when they called me was they would ask the questions on the left. What is the caseload? And what is the case mix? What will I learn in the next 3 years in your hospital, in your department? what is the clinical exposure like? Will you allow us to do procedures? What procedures am I supposed to be learning? Will I learn any of those procedures? How is the teaching quality like? What faculty do you have? Do you do any research? These were the questions that I was prepared for, but I was asked the questions on the right. Okay, so that really took me by surprise. That's our own experience. The second thing that I've noticed after AI came about is people who have seen us around in the ICU would have noticed when we ask questions, immediately the trainee goes at the back. So initially that really irritated me. This is like about 1.5, 2 years ago. Slowly I've gotten used to it, and I really wanted to, it is going to stay. This is not going to go away. I think Dr. Narendran also used, correct sir? Am I right? Yeah. So was it Claude? It doesn't hallucinate much and it's quite useful for us. So it is here to stay very much, and we have to live with it. It's like marriage. So you cannot run away from it. So deal with it. So we've decided that it is okay. So we ask questions even if they read from Claude or Perplexity or whatever they use, or up to date, anything. It is okay. They are reading. In the process of reading the answer for the question that we ask, something gets into their mind. It is okay. So we've accepted it. And nowadays, I just ask the question. If they look at me, I just say, yep, take it out, have a look. So that's what I do. So that's the other thing that has changed in our ICU. I've been teaching ATLS for the last 18 years. I started teaching in 2008. Recently, I became a director for ATLS courses. I've never faced situations like this in the past. I've taught in the UK, I've taught in Canada, and I've been teaching for the last probably about 12 years, since 2014 in India. The January ATLS course was a real wake-up call for us. When we do the courses, this is American College of Surgeons course, and it is mandatory that you collect the feedback from the learners about the teachers, about the instructors, and you give that back to the instructors so the instructors can learn from the feedback and change their method of delivery or whatever has been mentioned during the next course. Okay, that's how it works. It's always been reasonable. Usually they whinge about the timings. The majority of the times, in the last 12 years, what I've seen from the Indian students is the instructor was reading from the PowerPoint slides, and that was unnecessary. That was really not required. Then why should you have a slide if you're going to, you put 20 lines in there and you would just read it from the slides? That's not something that they would want. So that's a common feedback that you get from Indian learners. But this time, a female learner, she raised concerns that the learning environment was unsafe. I've only read these things in books, that what is a safe learning environment, what is an unsafe learning environment. This is real. I'm not making it up. I didn't know what to do. I was like, okay, the learning environment is unsafe means what? So we wanted to dig a little deep. These are anonymized feedbacks. You cannot find out although you can make out who would have written it, but you cannot call them and ask them. Then the whole point of having an anonymized feedback is gone. So it was specifically written that the teachers judge them based on their background. Some of them emergency medicine students, some of them surgeons, some of them orthopedic surgeons, some of them general medicine, some of them critical care, some of them pulmonology. Places of work and definitely treated them unfairly. So we had to rerun the whole show, and we had to retest them and administer some remedial measures. For the first time, I learned practically what an unsafe learning environment is in January 2026. And it is important to remember that Gen Z is social media savvy. Okay? So what we need to keep telling them is, you have to sit with them and talk to them, meet them, ask them, keep talking to them. If you fail to do that, your name might appear. This is all from Twitter. So there are two medical social media that at least I use. One is the Med Twitter, part of the Twitter, and the other one is Blue Sky. Blue Sky is more for critical care. So those are the only two things that I use regularly. This is picked from medical Twitter, recent ones, and I can get thousands of them if I search through in the last year. And this is all Chennai. And I just wanted to make it relevant here. 3 posts. One, if you read the left, I'm sure, Dr. Dominic, Dr. RKRS, we are kind of contemporaries. We will all realize what's happening there. During our final exams, we used to pool money to support the examiners, correct, sir? Yes? Yeah, we do that quite regularly. And that is as the professor taking bribe to pass students. And with the professor's name, the blanked area is the professor's picture, actual professor's picture, and it appeared on Twitter. And NMC was tagged. And there were so many responses, so many views. This is totally unnecessary, but then this is Gen Z for you. They take to social media really quickly. And this morning I was reading a post in the Indian Society of Anesthesiology. Some of you might be there. The Chennai group, and maybe some of our anesthesiologists may be in the Chennai group. There was a video posted by a senior man of a mother trying to train the daughter. Switch the lights off once you leave the room. Don't throw your towel in the corner. Wash your plates. Simple things that we teach our kids. And the ER head of MMC posted immediately saying, this is us, but if I do this for my daughter, then my daughter would post it in the social media saying calling this as toxic parenting. Okay, it's there this morning. Okay, so this is Gen Z for you. So they go outright, and if they don't like it, they can go to any extent. So that's general medicine on the left. The top one is pediatrics, the middle one is pathology, and the bottom one is INICET hospitals. Okay, nobody is spared. So who is Gen Z, born between 96 and 2012? So this is Claude as well. I'm learning to use the Claude software effectively, learning how to give commands so I get the output that I want. So their attention span, this is all research based, has dropped from 2.5 minutes in 2004 to just 47 seconds in 2023. So they don't have that much attention span that we used to have. And their screen average is between 7.5 to 9 hours. And the last point is important for us as teachers. Majority of them learn best from short video clips or infographics. Instead of, reading the full text PDF, if you summarize the full text PDF into a small infographic with all the information that is required, that's what attracts the Generation Z. They are digital native, not digital naive. They're value driven. That's why I put up the first slide. The questions that were asked by the prospective DRNB students, all of them asked about work-life balance. They never asked about caseload, what I will learn here. They wanted to make sure that they will be comfortable here. So the mental health awareness is definitely not optional for them, because many of them have learned through lockdown. This is probably the code batch that is going to come to us, and they were alone at that time. So that is kind of definitely having an impact. So who taught you versus who you are teaching? So on the left are the baby boomers. Some of our teachers who are still alive belong to that category, the baby boomers. Clearly, we had lectures. In my college, I don't know whether when you were there, whether it has changed. It was blackboard, white chalk, and some teachers had slide decks and slide projectors. That's all, no PowerPoint, no computer, nothing. It was written on the blackboard. That's how we learned, right, sir? Yes, I'm sure it's the same. It was lectures, hours and hours of lectures, material, no infographics, nothing catchy. It is just somebody talking, and it's up to you to grasp what you want. There was definite hierarchy. Information went up, ascended up to the boss, and whatever he wanted to convey descended down. So clear hierarchy was there. So CRRI, first year PG, second year PG, third year PG, assistant professor, associate, registrar, and then professor. That's how it was. And many of them adopted technology very late, and the baby boomers and Gen X, which is us, are pretty loyal to the institutions they work in or worked in. Compare that with the new generation. They prefer bite-sized material. They don't want to read 33 pages, 180, 240 pages of documents. They just want that to be summarized. That's what my son does. If he gets a PDF, he puts it in Claude. Claude summarizes it in 10 lines, and that's what he reads. They look at teachers as collaborators. There is no hierarchy there. As far as they are concerned, teachers are collaborators. So I had an opportunity to be in a medical college, just observe, I shouldn't say observe, moderate, maybe facilitate, not teach. So facilitate first year students. Okay. I thought we did 1.5, and then 1. They asked me to moderate a session in anatomy. I said, fine, okay, anatomy it is. Just go sit there. There were about 3 groups, and that one group was the one that I was moderating. They were given a case scenario. First year's case scenario, 82-year-old man coming in with some Lux symptoms. That's the scenario. And they had to read all about first what is prostate, man or woman, and then what does it do, etc., the anatomical part of it, the clinical part of it, and then they also read treatment. I was just sitting there moderating this. I was thinking what I did when I was in anatomy. Well, I just mugged up prostate and vomited in the exam and passed the exam. That's all I did, honest. That's all most of us did, right? So we didn't even understand what it was. We were in the dissection halls, and much of it just went away. But these guys, they prefer interactive classes, and they were born into technology, and they prefer that you give them proper feedback. Okay. So this is something that I've noticed in the last 2-3 years. For the learners, parents are heavily involved. I don't know. Vidya Madam can also shed some light on this. I don't know, because I am heavily involved in the progress of the children. When I was in college, my father knew nothing. He appeared for paying the first year fees, and that's it. I finished MBBS. Our batch was very unfortunate. We didn't have this graduation day, so I didn't get the degree. So my parents or family never came to the college. That's it. Only one visit to the college. But now, for my son, there's a WhatsApp group, there's a daily attendance, who comes, who doesn't. The test marks get posted in the WhatsApp group. If there is lack of attendance, I get an alert. There is an app. The app gives you notifications. I don't know, majority of the colleges have turned that way. I'm not sure about the private institutions, but I'm not sure about the government institutions, but many of the private institutions really track the children, and the parents get, minute by minute where they are and what they are doing. They didn't come for this afternoon's class. I get the messages. It's very unfortunate for the children, but that's how it has turned into. Okay. So that's about the learner. So you know that you are teaching a generation that kind of lived through COVID, is tech savvy, social media savvy. They speak less, they have a low attention span, and they prefer infographics and videos more than texts. How has the medical education changed? The middle part is the one that I was talking to you about, problem-based learning. I kind of understood what it was. I kind of heard about it, but I didn't know what problem-based learning was until I actually moderated that prostate session for the first year medical students. Certainly, when we were studying, it was long didactic lectures. Rote memorization was the norm, honestly. And now, you have YouTube, Insta, Facebook, you call it, it's all there. And for critical care, there is more. There is free open access medical education, and there is Internet Book of Critical Care, etc. So you really don't need a textbook, or they really don't need a textbook. That's the bottom line. So what other things have changed specifically in the Indian PG training? This has always been there. Service load, it leaves very little time for you to teach them. So you have to find innovative ways of teaching them. So 8 o'clock I start the round, 12:30 I have to talk to the families. In between I have to teach my trainees, residents, TMOs, etc. I have to find ways of fitting that in during the round somehow. Use 10 minutes, 2 minutes, 1 minute to teach a particular concept. So the kind of to put it all together, there's 7 shifts, and these are the shifts that has happened over the last 2 decades, and this is probably what the modern learner expects. They want relevance before context, just like how I started. Why am I talking about this today? And this is the reason. So I'll take 2 more minutes. That's 20 minutes. So they want relevance before context. And many of them want feedback. And the feedback, and there's a method to deliver the feedback called the sandwich method. I don't know if you're not aware of that, please do go look it up. And that is the right way of delivering feedback. The olden way of adu seriyave pannala kattunva, that is not the feedback the new generation accepts. You need to learn how to give proper feedback. Psychological safety, they definitely they ask for it. They need to make sure that it is safe for them, the environment is safe for them. So please, if they do ChatGPT or UpToDate, sometimes I join with them. Let's look it up on the computer, not on your mobile phone. Let's do it on the computer, UpToDate, open it up, put the disease, let's read together. People who have rounded with me would have noticed that I do that. Sometimes I voluntarily go to the computer and put it up. Let's read together. So because we are collaborators, we are not teachers anymore. So technology is definitely a partner, not a threat. As I mentioned before, it should be bite-sized. And they also want us to be human. So if you share your mistakes with them, it's more authentic, and they say, yeah, fine. Then that gives them confidence that, okay, so even if I might make mistakes, because I've heard from him that he has made mistakes, it is okay to make mistakes. At least they will get that kind of idea. And a bit of elaboration on the 3 or 4 shifts. On the left bottom corner, some of my colleagues don't allow phones during the rounds because it is disruptive. Because you are rounding 36 patients, you need to concentrate. You might miss the sodium, potassium, magnesium, calcium, image findings, what has happened yesterday, all those things, urine output, etc. you might miss. So many of my colleagues don't allow phones. A phone should be switched off or put in the nursing drawer, and then they start the rounds. I used to do that when I was in the previous hospital, but not anymore, because it is required nowadays. You don't shame residents for using UpToDate, Claude, whatever. Dr. Oracle is the other one that they use. It's medical AI. Apparently it's very good. I've not tried it. So that's kind of something that you need to remember. So the teacher is a human. I mentioned already that you share your own errors. Definitely, that kind of gives them some confidence, and they will interact better. I'll skip this 5 micro skills. And the 10-minute water round, this is something I learned. How do I effectively utilize the water round and teach something in that short period of time? So start with, we have a patient in bed 1 with severe diabetic ketoacidosis. So that's the patient. Start with the problem. Second, ask the learner, what would you do next? They presented with a pH of 6.9. What would you do next? They should be in a position to explain what they would do. And if they give you a wrong answer, that is your teaching point. And that's where you stop them or gently pause them. Shouldn't say stop anymore. So pause them and that is your teaching point. Pause and start explaining and teach one thing. So we have this urge that, thus the 100 things that I learned about Parkinson's should be taught today to the 50 people sitting in this hall. No, that's not going to be effective, and nobody will learn anything. Not even a single point will go into our minds. So pick one point and go really deep into that particular point. Don't kind of surf and don't do a shallow 50-point teaching. That's not going to work. So just one point or one thing that they can take home, learn. Always check their understanding. And finally, feedback, and that's called the sandwich method. You did well. You attempted an answer. That's great. And then you talked about whatever you talked about, and if maybe next time you should do all of this. And that's how you provide feedback to your trainees. This is other concept of 10-minute word round, and this is what is called a flipped classroom. This is, I don't know about the other specialties, happening left, right and center in critical care every day. There are like 1 million WhatsApp groups. Because of ChatGPT, everyone is creating an infographic, and every day we get about 50 infographics, at least 5 on sodium and 3 on arterial blood gas disorders, and at least 5 on imaging in critical care, something like that. Yeah. So you send a clinical vignette. Tomorrow is going to be the class. You send bed 1 is what we're going to discuss tomorrow. You're not going to teach basics, how decay happens, etc. Because even this morning, our resident, one of our residents approached me and said, "Sir, we are getting, every week we are having classes. That is great, but we don't want theory classes. I can read them. There are books and there is material. I don't want you to teach theory. I want only case-based discussions. I want you to share your expertise, the problems, the differentials that goes through your mind, and how you make that diagnosis you make is what I want to know. I don't want to know the process of decay, how ketone is formed, how beta hydroxybutyrate is measured, why serum ketone is better than. I don't want to know. It's out in the internet. I can read it up. This morning, I'm not making it up. This is honest. Okay. And finally, you do a 1-slide summary. After you've done all of that, this takes about 15 minutes. You don't teach basics. It's only case discussion. Your job is to facilitate. You're not lecturing. And you give a 1-slide summary in the end. So that's my summary slide. Modern learners are different. Definitely they are different. They are digital native. They have much more knowledge in AI than you and I do. Teaching has definitely transformed. There are lots of different methods that we can adopt to teach. That's kind of, I really liked that from Sage on a stage was our medicine professor. To guide on the slide is halfway through during my PG days, and information is now free. And the 7 key shifts that I talked about: practical tools, 10-minute word round, micro skills, and there's a technique called 5-stage approach that we use to teach procedures. And they are not demanding less rigor from us. They're not asking us to teach them less. They just want us to teach them differently. That's all. So they're just demanding a different delivery. So I started with teaching by humiliation. I'm ending with a slide on teaching by humiliation. It is still, if you can, I don't know, it's too small for you to read. 90.8% of the graduating US medical students have encountered teaching by humiliation, and this is 2025 data. That has not changed, and that needs to change. Thank you. So on this occasion, ma'am, I'll give you that example, the actual example. None of the people here attended the course. It's not relevant for them.
Unsafe, maybe getting all the viruses.
No, ma'am, no. Unsafe environment is me being judgmental. Okay. So sorry, I'm going to pick on you, if that's okay. Nothing personal. So she's an oncologist. She attends a trauma course. So what do you know about trauma as an oncologist? You don't manage trauma. Why are you here? And that is the reason why you are not able to demonstrate pelvic binding. You don't know how to measure cervical. That was a post MBBS doctor who was aspiring to go to the UK for future for further studies, and the teacher talked to her like that. Why would you even do a trauma course after MBBS? You have not started seeing patients. How many trauma cases have you managed? Nil means, I'm really sorry, doctor, it's nothing personal, nothing to do with you, just giving an example, that's all. Don't mistake me. So that's an unsafe learning environment, because the person couldn't stand there. They had the urge to leave that particular workstation.